What is Elrexfio?
So this is a very unique type of an immunotherapy. So Elrexfio, or in the medical terminology, Elranatamab. So the MAB stands for monoclonal antibody, is a bispecific antibody. So think about this bispecific antibody having two arms. So with one arm, it is hooking the myeloma cell. With the other arm, it is hooking the T cell. T cells are the ones that kill the myeloma cells. So you're bringing both of them together in proximity so that you're allowing for a T cell directed myeloma cell kill. Previous approval for a similar kind of a bispecific antibody is for teclistamab in myeloma. So we have a second bispecific antibody targeting the BCMA as well as the CD3 on the T cells. So one can ask, why BCMA? So what is BCMA? So B cell maturation antigen is a protein that is present on the myeloma cells that could be used as a target. An ideal target is something that has to be specifically present on a target cell. So here, for us, the target cell is the myeloma cell. And you should have minimal expression on the surrounding tissues. So the target antigen should have minimal expression on the normal tissue so that you minimize the off-target side effects. So you only want the on-target effect, which is the drug has to go bind to the myeloma cell and allow for the cell kill to happen with the T cells. So now in here, where is BCMA seen? BCMA is seen in all mature B cells, and it is also seen in some normal cells like the RBCs, like some other hematological cells, or early the progenitor cells that we can see, but not in the non-hematological space. So that makes it the beauty of this drug. Why we went all after this specific target is the minimal expression on the other tissues and the maximal expression on the target cell that we have.
What is the current indication for Elrexfio? Who is Elrexfio approved for?
So let me start with talking about what is Elrexfio approved for today. So Elrexfio, or Elranatamab, is approved for multiple myeloma patients who had received 4 prior lines of therapy, including an IMiD, a PI, CD38 monoclonal antibody, and making altogether 4 different lines of therapy. So let me break it down by what is a line of therapy. So in simple terms, one can ask the question, how many times have you progressed? And in each progression, there is a change in the therapy. So that is the simplest or the dirty way of calculating how many lines of therapy people have. For example, somebody has an induction therapy with RVD, somebody has a transplant, then has maintenance. That all counts as one line of therapy. So it is not uncommon that we have this discussion in the clinics every day. So why are these not considered as 3 different lines of therapy? Because you have not progressed 3 different times. You have not progressed at all. So once patients are progressing on the Revlimid maintenance, so that is considered as one line of therapy. Whichever the next line is started is the second line of therapy. So every time when there is a progression, there's a change in the treatment, and that change in the treatment counts for one line of therapy. So I hope I made it a little simpler for people to understand. So in those lines of therapy, you need to use an IMiD, which is either POM or REV or THAL. You have to use a PI, which is ixazomib, bortezomib, or carfilzomib, and a CD38 monoclonal antibody, which is, we only have 2 of them approved so far, which are daratumumab or isatuximab. You have to see those lines of therapy. To fit those lines of therapy, you have to see those exposures to these drugs before you get qualified for elranatamab.
What was the name of the trial that led to accelerated approval, and what were the main findings?
With the prior approval of teclistamab, we saw a response rate of 60 to 63% for these patients who were heavily refractory, who had seen 6 prior lines of therapy. Here, with elranatamab, patients are much more refractory with 7 prior lines of therapy, and these patients had a response rate of close to 60%. So 2 in 3 people responded to the drug, and these are good responses, and this is a heavily refractory patient population. MagnetisMM-3 is the trial that showed the response rates that we talked about at 60%, and these are deeper responses. Most of the patients, 90% of the patients that had a response had greater than VGPR. Based on the initial response rate of 60%, we're approving this drug based on an accelerated approval. Nevertheless, there is a caveat that you need to prove to us that this drug is active against the standard of care. There is an ongoing confirmatory trial to make this accelerated approval a real approval, a full approval, and those trials are ongoing, cooking at this time, and we hope to anticipate to get those results possibly within the next 2 years or so.
How is Elrexfio administered and what is the dosage?
It's a subcutaneous administration. It is given on the belly. When you talk about Elrexfio, it is given in 3 different dosings. So it's called a priming dose. There's a dose at 12 milligram as a flat dose that is given first. The second priming dose is given 48 hours later. And the third dose is given another 48 hours after, that is the third dose or the target dose. So think about this: priming dose, target dose. So each of them are separated by 48 hours. So 12 milligram, 32 milligram, 76 milligram. And these are all flat doses. So now if you look at the REMS program, what is a REMS program? It's called the Risk Evaluation and Mitigation Strategy. So this is a program that helps with certain drugs that have a higher risk to minimize the risks. And the recommendation for the REMS program is to hospitalize patients who are receiving Elranatamab for 48 hours after the first dose, 24 hours after the second dose, and the patient could be discharged. Because the risks of cytokine release syndrome are so predictable, they happen very, very early in the course. So that is how it is designed, and that is what the package insert looks like.
After you receive your first full treatment dose, Elrexfio is usually given one time each week through week 24. Starting on week 25, your future doses will usually be given one time every 2 weeks for patients who have received at least 24 weeks of treatment with Elrexfio and have achieved a partial response or better and maintained this response for at least 2 months. Elrexfio is a fixed dose with no weight-based calculations. Patients should continue treatment with Elrexfio until disease progression or unacceptable toxicity. Can biweekly dosing start sooner than week 25?
So here, what I clearly say is, once we achieve a good response, there's always the decision between the patient and the physician to say, hey, is this the time where I could say, we got the response, now we want to maintain the response. Can we ease off on the pressure that we're putting on the immune system and try to let the function to recover? So rather than constantly bombarding these T cells. And we have seen the data that by going to every other week at a later time, after the 26 weeks or so after the first 6 months to go to every other week, that is how the trial has been designed. But if you achieve a complete response or a great response, more than VGPR in the first 2 months, I would challenge why you should not go to every other week at this point. So I'll be ending up in trouble because I'm questioning the dogma. But that's what I'd really love to do for my patients, to see when is the right time for us to see when we can peel off the drugs that they don't need. So we need to come off that mindset that more is good. So minimal effective dosing is how we want to go.
Please note that the prescribing instructions state that patients who have received at least 24 weeks of treatment with Elrexfio and have achieved a partial response or better and maintained this response for at least 2 months can switch to biweekly dosing. If you are considering switching to biweekly dosing sooner, this is a decision you must make with your treating physician. Are any prophylactic medications given before an Elrexfio injection?
What we typically do is go as a pre-medications using some Benadryl, using some Tylenol for every patient that receives with every dose. So that's what we typically do as pre-medications for everyone. In our practice, we give every single time.
According to the prescribing instructions, premedications should be administered 1 hour before the Elrexfio injection for both step-up doses, days 1 and 4, as well as for the first treatment dose, day 8. Premedications include acetaminophen or Tylenol or the equivalent, dexamethasone or the equivalent, diphenhydramine or Benadryl or the equivalent. What are the biggest risks associated with Elrexfio?
The biggest risk for giving elranatamab-like drugs is mostly the CRS and the neurotoxicity that you're worried about.
What is cytokine release syndrome? When is CRS most likely to occur and how is it managed?
So the cytokines are released from the body when there is an active myeloma cell kill. This is a immune stimulation that is happening where the body is responding by releasing these cytokines.
CRS is common during treatment with Elrexfio and can also be serious, life-threatening, or can lead to death. Tell your healthcare provider or get medical help right away if you develop any signs or symptoms of CRS, including a fever of 100.4 degrees Fahrenheit, 38 degrees Celsius or higher, trouble breathing, chills, dizziness or lightheadedness, fast heartbeat, or a headache.
CRS happens very frequently. Almost two-thirds of the patients have these, and very rarely, less than 1% of the patients, where it's a grade 3. So how do we grade them first? So grade 1 is the time where somebody has a minor fever, they have a grade 1. Grade 2 is the one there's a sustained fever, there are simple metrics of oxygenation and everything that we look at to grade them into grade 2. So the higher the grade it is, the bad it is. So we don't want higher grade toxicities to happen. So if somebody is seeing a grade 1 or grade 2, we always want to mitigate it by giving a prophylactic treatment. So this is all about the CRS. So now let's talk about when this happens. So all of what we see in terms of the CRS is happening right in between the first and second dose and earlier as close to the second dose as possible. That is why the REMS program has been designed that way. Can we do something more prophylactically to prevent that CRS? So we have gone in the past with what is called the ASTCT guidelines. ASTCT guidelines say if somebody has a greater than grade 2 CRS, they're the ones that would need the tocilizumab. And we learned very quickly that we don't need to wait for somebody to go from grade 1 to grade 2. Everything has to start at a grade 1. It doesn't start at a grade 2. If you're seeing those early signs of those grade 1 CRS, we could just start and act with this an antidote, which is the tocilizumab that is given again as a shot. It can be given 3 times every 8 hours apart, but most patients that receive the bispecific antibodies will need only 1 shot. Despite whatever we're talking about giving this prophylaxis with the TOCI or treatment with the TOCI, everyone gets a Tylenol and Benadryl prior to each of these dosings as the real prophylaxis, just like how we do for any blood transfusions.
In addition to CRS, neurologic toxicity occurred in 59% of patients. Most neurological toxicities were grade 1 and 2. Grade 3 or 4 toxicity occurred in 7% of patients. Neurologic toxicities included headache 18%, changes in mental function 15%, motor dysfunction 13%, sensory neuropathy 13%, and Guillain-Barré syndrome 0.5%. In the clinical trial, ICANS occurred in 3.3% of patients who received Elrexfio at the recommended dose. Most patients had ICANS after the first step-up dose. 1 patient had ICANS after the second step-up dose, and 1 patient had ICANS after subsequent doses. Recurrent ICANS occurred in 1.1% of patients. What is ICANS?
So ICANS is a very unique concept meant for the T-cell directed therapies. It's called the immune cell effector neurotoxicity syndrome. We still fully don't understand the exact mechanism of why ICANS happens, and it is seen in lesser patients than what we see with the CRS. So if you look at all grade neurotoxicity, count like as a headache, as somebody that woke up, you're waking up the patients at 3 a.m. and asking them to do this mini mental status exam, those numbers can be high. But I don't want you to be scared about that. The real problems that I always think about are the grade 3 or higher toxicities where patients can present with seizures. Patients can have obtundation, then they don't know where they are. They're in a temporary phase where they're not in the room. So those are the higher grade neurotoxicities. Those can be seen in less than 2 to 3% of the patients. It's a very, very small number, but these are always reversible, as we can see. And fortunately, with elranatamab that we see, the risk is almost negligible.
The median time to onset of ICANS was 3 days after the most recent dose, with a median duration of 2 days. The most frequent clinical manifestations of ICANS included a depressed level of consciousness and grade 1 or grade 2 immune effector cell-associated encephalopathy scores. The onset of ICANS can be concurrent with CRS, following resolution of CRS, or in the absence of CRS. Patients are advised not to drive or operate heavy or potentially dangerous machinery for 48 hours after completing each of the 2 step-up doses and the first treatment dose within the Elrexfio step-up dosing schedule, and in the event of new onset of any neurologic toxicity symptoms until symptoms resolve. What is hypogammaglobulinemia?
As we talked about how these drugs work, the plasma cells are the ones that make the immunoglobulins. So here we're going against a war against the plasma cells. So not just the myeloma cells, all plasma cells. So which means the normal immunoglobulins that your normal plasma cells make are all invaded by the T cells that are being redirected by these bispecific antibodies. So which means, in essence, what do you expect? There's not as many plasma cells making as many antibodies. So the quantitative levels of these immunoglobulins drop and drop and drop as we see with the continuous administration of these drugs. So do we have to rely on the plasma cells to make the antibodies? Absolutely yes. And at the same time, this is one of the mechanisms I was talking about, why it is so imperative for us, once you achieve a response, you need to peel off these drugs, extend the intervals so that the plasma cells have a breathing space so that they would be able to make those antibodies. But until the time you're at a higher risk for infections with low immunoglobulins, and that is the place where we have historically used artificial immunoglobulins to replace the immunoglobulins that are not being made by the body.
Artificial intravenous immunoglobulin, or IVIG, is a pooled antibody and a biological agent used to manage various immunodeficiency states. IVIG can be very effective at preventing or treating infections in persons who do not have antibodies or who have low levels of antibodies. IVIG is prepared from the blood donated by thousands of people to make a super concentrated and very diverse collection of antibodies against many possible infectious organisms your body might encounter. The ultimate goal of this therapy is to normalize a compromised immune system. How can infection risk be minimized?
When it comes to infections, we always are very, very cautious. So the first thing that I say, this is a time of the year where we all get the vaccinations. So people get the flu shot, people get the RSV shot, people have the COVID boosters. So all of those, I always tell that the best way that you can do, how can you do something to help yourself? Number one, increase your layers of protection, increasing your layers of security to prevent any of these infections. Number one, get all these vaccines. Number two, get the IVIG, artificial immunoglobulins that your body is not able to produce because we're knocking off all these B cells. Number three, so taking some antivirals. If there's a risk of any specific viral reactivation, we want to give those viral suppressives so that you suppress the reactivations. So these are all of what we say, should I get this or should I not get this is not the question that we want to ask. What we want to ask is, what is the best chance that I have to minimize all these complications is how I'd be looking at. So if I'm able to do all these of what we talked about, so the risk of infection minimizes drastically. That still doesn't say the infection risk is zero. Infection risk still stays higher. So still you need to follow all your precautions that you normally do.
What prophylactic medications would you recommend while taking Elrexfio?
Acyclovir is something that I would leave on all my patients that ever receive any myeloma therapy. The reason is herpes zoster or shingles virus is something that's already in all of our bodies. So it's a matter of time when there is a immune suppression, the virus pops up. So it's not about having a zoster at one time. It leaves the sequelae, it leaves that residual pain forever. If somebody had shingles once, they can tell you how bad it is at where they had the shingles for the rest of their life. So everybody gets acyclovir in my practice, or valcyclovir. So the second one, you talked about Bactrim, great point. Bactrim also has some side effects. So Bactrim side effects are cytopenias, and in terms of in trying to help a patient, we don't want to harm. So that's why I peel away on the Bactrim. I don't use it as much. But in somebody that becomes lymphopenic, that becomes low lymphopenia, low lymphocyte counts, and those are the patients that I introduce Bactrim at a later time, so that the patients do not acquire this immunosuppressive pneumonia uh, that you see in the immunosuppressed patients called the PJP pneumonia.
Different medical facilities have varying views on the use of Bactrim. Please discuss the use of Bactrim with your medical team.
But in general, if you're treating it, if you're looking for the other supportive medications, we talked about the IVIG, we talked about all the vaccines, we talked about acyclovir. Those are the main things that I tend to do on a regular basis. But I'll have a very less threshold for somebody to start an antibiotic on someone. Say, for example, if somebody is coughing, sneezing, and acquiring an infection very quickly, my threshold to start an antibiotic is very, very quick among patients that are receiving bispecific antibody. Otherwise, those infections can be really dangerous.
In addition to CRS, neurotoxicities, and increased risk of infections due to hypogammaglobulinemia or cytopenias. The most common side effects of Elrexfio include tiredness, injection site reaction, such as redness, itching, pain, bruising, rash, swelling, and tenderness, diarrhea, muscle and bone pain, decreased appetite, rash, cough, nausea, and a fever. The most common severe abnormal lab test results with Elrexfio include decreased white blood cells, red blood cells, and platelets. Elrexfio can cause increased liver enzymes and bilirubin in your blood. These increases can happen with or without you also having CRS. Tell your healthcare provider team if you develop any of the following signs or symptoms of a liver problem: tiredness, loss of appetite, pain in your right upper stomach area or abdomen, yellowing of your skin or the white part of your eyes, or dark urine. Your healthcare provider will check your blood and monitor you for signs and symptoms of these serious side effects before you start and during treatment with Elrexfio, and may temporarily or completely stop treatment with Elrexfio if you develop certain side effects. These are not all of the possible side effects of Elrexfio. If I had a previous BCMA-directed therapy, can I still respond?
This is a great question. So we presented this data at ASCO of 2023. So what was done at ASCO 2023 was we looked at the magnetism pool trials. So we looked at all the patients that have ever received a prior BCMA targeting therapy, like an ADC. We talked about belantamab, like a CAR T, the ide-cel or cilta-cel. So among those patients, what kind of responses are you seeing by using Elranatamab? So that was a trial that used 4 different trials. So 9 patients from MagnetisMM study, 64 patients from MagnetisMM study, 1 patient from MagnetisMM. So we have a pool of patients together. These are close to 87 patients that received Elranatamab among those who had received a prior ADC or a prior CAR T. Majority of these patients, 59 of them, received prior belantamab. If you look at those specific responses, you're seeing those responses in close to 42% of the patients. Among patients who had seen prior CAR T, they may have received CAR T a while ago. They've not been on any continuous therapy, and those are the patients that had the best response. You're seeing 52% of those patients responded. So compare these responses to what we had in the past, even from the past, even from Sally, even from Bella. We were seeing a third of the patients responding. Here, there are a significant number of patients that are responding down the line. I'm not saying that there's no role for Sally or Bella. They probably might be happening at a later time, but at this time, these responses among patients who are hexadrug refractory. So these patients not only had seen 2 PIs, 2 IMiDs, and a CD38 monoclonal antibody, they also have seen a prior BCMA, ADC, or CAR T. And these patients who had seen 8 prior lines of therapy, you're seeing 50% response rates. That means this is a very effective treatment. The PFS benefit that you see among patients who had seen a prior CAR T is in the range of around 10 months. The PFS benefit that you see among patients that had seen a prior ADC or belantamab was in the range of around 5 months. And patients were living a year after, on an average, when you see patients who are progressing on prior ADC or a CAR T. the biggest question that we all have is, number one, are the toxicities increased if you're reusing this CAR T, this BCMA bispecific ADC Elranatamab? So the answer is no. We did not see any increased risk of CRS. We did not see any increased risk of infections. Did not see any increased risk of cytopenias. So it's a very safe drug to be reused in case a chance happens that you have the availability of the drug and this is right in front of you, and this is a choice of therapy for patients who had seen previous ADC or a CAR T.
What is the Patient Access Navigator program? If you've been prescribed Elrexfio, you can receive one-on-one support from a Pfizer Patient Access Navigator during your treatment. To get support from a Patient Access Navigator, enroll in Pfizer Oncology Together. After you enroll and opt in, you will be assigned a Patient Access Navigator who will work directly with you and your care team. Patient Access Navigators can help you access Elrexfio by providing details to help you navigate your insurance coverage, including letting you and your care team know how much of your treatment is covered by insurance and what your out-of-pocket costs may be, connecting you to financial assistance resources if you're eligible, regardless of insurance type. If you need financial assistance to help you pay for your medicine, they can help identify potential resources for patients with commercial insurance, Medicare or government insurance, or those who don't have insurance, helping you identify solutions if you run into any challenges when accessing your treatment. Patient Access Navigators can help you as you begin treatment with Elrexfio by confirming your hospital's discharge plan with you and your care team if you're receiving your first week's doses at the hospital, and providing you with the information you need to receive treatment at your healthcare provider's office. Patient Access Navigators can help support you during your treatment with Elrexfio by coordinating with you to confirm logistics, providing appointment reminders, and following up on insurance needs. Call 1-877-744-5671 or visit PfizerOncologyTogether.com.